Fabian. So my name is Eva and I am Ugandan. I'm happy to be here. Thank you so much for the invitation. I am waiting for my slides to come up. Okay, there we are. So I am going to talk about the status of IR in both training and practice in my country. I have nothing to disclose. I'll start by telling you about my country. So my country is a small nation of 45 million people in East Africa, right at the equator. It's a young country. The median age is 16. So I only feel young when I travel. And it's a very beautiful country. It's really gifted by nature. What we don't have in my country is interventional radiology. Like Fabian has already told us, we had 0 IRs for the entire population of 45 million. And like you've already heard, this is really what Africa looks like. The countries in yellow are countries with a diagnostic radiology program. And at the time we were looking, only the countries in green had intervention radiology training programs. What was interesting for me was the fact that our neighbors actually had intervention radiology training programs. So we reached out to Tanzania to find out how they had done it. And that's how we learned about this Road to IR training model that Fabian has already told you about. They do these high-frequency 2-weekly teaching trips to countries, and they train people in their local countries. So immediately I looked at what we had as a country. I work at this institution called Mulago National Referral Hospital. It's the largest public hospital in my country. It has bed capacity of 1,790. It's a major teaching institution for Makerere University, which is a university that has been standing for 100 years. And we've been training diagnostic radiology for over 50 years. We had ultrasound, CT scans, diagnostic radiology, fluoroscopy, and most importantly, we had administration support. Actually, right now, our CEO is a radiologist, and so when we talked to her, she knew exactly what we were talking about. And with all that support, we just got to work and developed a training curriculum, a 2-year fellowship program. In the first year, we really do non-vascular procedures, and then in the second year, we start doing the vascular procedures. We were not humble about our launch. When we launched 27 months ago, we invited everyone. We invited the media. We told the story of what we were doing. And 27 months later, we've graduated our first class. That's myself and 2 of my colleagues. That we've had 27 teams come to Uganda, so we've had a team every month. And I say team because it's not just the IR person who comes. They come with their techs and nurses. They've come from everywhere. What's interesting for me about this is they've come from Tanzania, they've come from Kenya, they've come from South Africa. Proof that help for Africa can actually come from Africa. This is where we stand right now. We have had over 2,400 consultations in the country. This is it, by the way. When I speak for my institution, I speak for the country, because right now it's the only place where you can get any IR services. And we've had a total of 1,047 procedures. The clinic visits are training up, the procedures are training up, and most of our procedures are guided by ultrasound, but we also do CT guided procedures, fluoroscopy guided procedures. Majority of them are drains and biopsies, but we also do these other ones, like this 47-year-old man who came to us with a ruptured subcapsular HCC. You can see it there in segment 4. And we were able to access the hepatic artery, go to the subselect the vessel that is bleeding, and then embolize, as you can see in this final picture over there. And then you're doing a good job when you get a call for help. This one came recently from urology. So before we started our program, urology used to do all the percutaneous nephrostomies. And they called us for this one. They had put a drain in, and instead of getting urine, they got fresh blood. And luckily enough, it was a working day. We were open. We still work Monday to Friday. And what we didn't really understand where the catheter was, where the pigtail catheter was. So even when we injected through the pigtail, we were not able to opacify anything. And so we accessed the lower pole calyx because it was still dilated, and inserted a PCN after sending a wire all the way to the ureter, inserted our pigtail catheter into the renal pelvis. This threw us off a little bit, but it was a duplicated system. That's why you see contrast going all, up there. And finally, we pulled out the urology catheter over wire and realized actually we had a pseudoaneurysm that was the cause of the bleeding. And we're able to go in there and deploy our coils and do the embolization. And that was our final run. Like Professor Wilder said, there's so many challenges. We don't have equipment. We still share cardiology space, and you all know how that goes. The supply chain has been talked about. And obviously personnel is a challenge because we're just coming up and training our team right now. Thank you so much for listening. Uganda is a beautiful country. I invite you to join us.
Any questions for Eva? Yeah, go ahead, Philip.
Yes, thank you, Eva, for nice presentation and promising presentation. I have one question. On one slide, you present more than 2,000 consultations and more or less only 1,000 interventions they have. What was the reason potentially to refuse 1,000 potential patients?
So many times it's things that shouldn't come to IR in the first place. And I think this is a good problem because people in my country are really excited about IR. I didn't show any pictures here, but when we have our IR lectures with our visiting faculty, it's not the 3 trainees that attend the lectures. It's almost the entire hospital. So we'll have surgeons, pediatric surgeons. There's just so much excitement about what we can do. And so we often get calls about things that should not even come to IR. But we like that problem. And we encourage people to come to us because I think often it's the other way around, you have resistance. That's not what we have in our country. There's a need and people recognize what we can do and they send the people to us. But I think it's also because we are a tertiary referral center for the country. And so we get people coming from everywhere. So the entire population of 45 million and beyond, we're talking South Sudan, Congo, Eritrea. So that's partly why the numbers look like that. Every once in a while, you will get patients that really deserve a procedure, but then you don't have either the consumables or the expertise to do it. And you have to group those patients, if it's not an emergency, to wait for when you have faculty coming in. So that was a problem initially. Now, not so much, but those are some of the reasons you see just 50% of the consultations getting a procedure.
That's very good, Eva. I mean, she touched up on, these are in my experience, especially in sub-Saharan Africa, the 2 categories is, it is an IR indication and an IR patient, but you do not have the resources or expertise to do it, so it counts as a consult, but never formulates into a procedure because you couldn't do it. But the other category is very important, is it's really not an IR case.
Yeah.
It's not indicated. So we were in Ethiopia, for example, we did a biopsy clinic. They brought us 5 patients for biopsies. We didn't do 1 biopsy that day. We basically turned down all 5 of them because they were not really, they did not, one was an angiomyolipoma, one was a mesenteric mass, which was actually an SMA aneurysm.
Yeah.
You know,
That's
so
very common.
none of them are indications, and I'm not trying to trivialize it, but it's a reflection of
It's a very real problem. Yes.
of a rural, is that IR is very high level sophisticated medicine, and you're dealing with a developing country, developing medical system that doesn't know how to use this highly advanced skill set and tool. So they send you things that actually, it would be more dangerous that we do something to them. So that's why you get these numbers are off.
Okay, thank you.
Thank you